We begin our third part in looking at the bones and skeletal tissue, and then we'll continue on into joints. So for fractures that we just got done discussing in part two, those fractures need to heal. And so the process itself is basically a three-stage process in which the first stage is forming a hematoma, or essentially a big blood clot. And so this blood clot is going to form within the fracture itself. One of the things that's, in a sense, generally deceptive kind of about this picture here is that the periosteum is still intact, and so usually that periosteum is going to be broken as well, and blood is going to leak out into the area. And so, as you know, when somebody has a fracture, generally one of the first things besides pain and so on that they may be experiencing is going to be swelling, is going to be bruising in the locally area where that fracture has occurred. Once that hematoma has occurred, we've clotted off all the blood vessels. Now it's time to start the process of healing. And so within this process, within the first couple of weeks of the fracture itself, usually by 2 weeks, we start to see what we call a fibrocartilaginous callus. And so essentially this is a combination of the bone starting to heal. And so we start to see some trabeculae of spongy bone starting to cross over the gap itself. That's there. And we have phagocytes coming in, cleaning up any kind of fragments of the bone, cleaning up any of the blood that has been clotted in the area, generally getting rid of any debris that is in the space itself. And so this is usually visible on x-ray, and usually this is where you go back after 2 weeks or so and the x-ray again and make sure everything's starting to heal. So this fibrocartilaginous callus itself, we have a large number of osteoblastic activity, and so they're starting to lay down kind of the basis of the new bone that is there. So we do that by laying down collagen fibers. Those collagen fibers then become ossified over by the matrix that's being formed by the osteoblast, and we start to see all of this kind of solid bone forming. And it's going to be in the form of trabeculae kind of crossing the gap and bridging the gap, creating a connection between the two sides that are there. New blood vessels are going to come across the gap as well within the broken bones themselves, so that we resupply both ends of the bone with blood supply. Otherwise, we may end up with necrotic bone. So those blood vessels have to get across both ends of the bones. At times, there are bones where this process does not occur, and if that is the only blood vessel that comes in here and supplies this distal end of the bone, that distal end of that bone, or proximal end, whichever it happens to be, may end up dying off. But in the case here, we have our new bone growing, and within usually 3 to 4 weeks or so, we're going to start to see a bony callus. And at this point, basically, we have the two sides of the bone re-intact, and so they're back together with one another. Both the fibrocartilaginous callus and the bony callus, you can kind of think about of being something like a scab that you have if you were to like scrape your knee or something like that. They're filling in the gap. They're not the finished product. They are what we're going to want to have to be able to keep that tissue intact at that point. At this point, usually when we see a bony callus, this is where essentially healing is pretty much declared on x-ray. And this is where essentially you can usually come out of a cast, maybe keep on protecting it depending upon how well that bony callus has formed at that point. But the healing process is not done. We're not going to have complete solid bone there for the next couple of months. And so it's going to continue to go through modeling and remodeling to get that bone back to a normal structure. We've got to clean up the medullary cavity if it's a long bone. And so we've got to clean out all of the extra bone that would have been inside there. We need compact bone to continue to grow on the outside. So we've got to replace all of that trabecular bone with compact bone on the sides there, so that we get it back to looking relatively normal. But the thing that is going to be about that bone at this point is we're still going to see, in a sense, kind of this bulge on the bone where that callus was for some time. So this is going to stick around there and may even be there for the rest of the life of the person, depending upon the bone, depending upon the stress that's being put on that bone. When bone has inadequate uh, products in order to make normal bone, one of the things that we may start to see is things like osteoporosis. And so with this, it's not necessarily that we have a lack of calcium or things like that within the bone itself, but it's where we don't have the ability to stimulate the cells well enough in order to cause bone deposition. And so osteoporosis is essentially where osteoclastic activity is outpacing osteoblastic activity. So the osteoclasts are breaking down bone faster than the osteoblasts can build it back up. This is most common in postmenopausal women simply because they're lacking in estrogen, and estrogen is one of the stimulants for bone deposition, for that osteoblastic activity. And this can lead to, especially in porous bone and spongy bone, fractures just by simply doing kind of normal daily activities. Sneezing causing or even coughing causing something like a compression fracture in the vertebrae. So here we can see the difference between the bone. It's not that the bone is gone per se, but it's that all of that spongy portion of the bone almost looks like it's been eaten away. There's been pieces of it taken away out of the bone itself compared to the normal bone where all of those trabeculae look nice and solid inside there. All the lining cells are keeping that bone well intact. Treatment essentially comes primarily in terms of osteoporosis comes in prevention. And so increasing calcium and vitamin D when one is younger, making sure that the bone density that is there is strong before they get to menopause. But if they are going into osteoporosis and maybe they're in osteopenia before that, increasing weight-bearing exercise, increasing calcium and vitamin D supplements, there's been mixed results in terms of the research that as far as when and how much all of those may start to have an effect on osteoporosis itself. One disease that may affect males more than females is Paget's disease. And so this one here is kind of the opposite of osteoporosis. And so rather than taking away bone density, this is going to add bone. But the thing is that when it adds the bone to it, that bone is not very well organized per se. It's not the normal process that it should be. And so typically, in terms of the amount of bone that's there, we end up with a large amount of woven bone or spongy bone compared to that of compact bone. And so although we're laying down lots and lots and lots of bone, the osteoblastic activity is very high. The osteoclastic activity for doing the normal remodeling is not. So this is where we end up getting excess bone deposition compared to it being remodeled back down. Common places to see it are places like the pelvis and the skull. Again, it has a higher male uh, predominance than that of females. Don't really know why its cause is. It just happens, and it may be a series of environmental factors, everything from infections in the past to other things that are found in the environment itself, and then a little bit of probably genetics as well. One of the ways that we can use to detect things like Paget's disease are bone scans. And so they're not done as often anymore, but they do have the ability to see pretty well things that are growing in bone, as well as if bone is no longer alive. And so what we see is what we call hot spots and cold spots. And so hot spots are areas where we have metabolic activity that is in extra proportion to that of the rest of the bone. And then we have cold spots where there's basically no bone activity. And so the radioactive tracer that is given is going to go primarily to bone that is actively laying down new bone. And when we see that, we see it as kind of like a reverse x-ray. The radioactive material goes into the person, and then they scan it as it comes out. And so you can find things like occult fractures, things that just don't show up on X-ray or CT scan even potentially, but that's where CT scans and MRIs have kind of taken over that of the bone scan, but it still has its uses. Developmentally, bone develops from, as other connective tissues, from mesoderm. And so we start out as those mesenchymal cells. We have all of that mesenchyme, and then we're either going to go through a process of endochondral ossification or intramembranous ossification for each one. Both the embryonic skeleton as well as the ossification of bones after birth follow a very predictable timeline. And so we can see different bones starting to ossify during the fetal stages and be able to kind of gauge how old a fetus is through things like ultrasound and even x-ray and see what's going on those. And then after birth, we're going to have the same kind of timeline of bone ossification as we had for the early development of the bones themselves. Generally, by about age 25, all of the bones have completely ossified. There may be some changes that occur a little bit, but generally the last of the growing bones has done so by the age of 25. And then we're going to have some changes that occur within things like the sacrum and the coccyx as far as fusion goes and things like that as we get into that time period, and that can kind of change up or down depending upon the person itself. As we get older, osteoblastic activity tends to wane a little bit, and so the osteoclasts tend to take away more bone, so we start to decrease that level of density that is there. And so that's why earlier in life, having a greater amount of bone mass is protective against things like osteoporosis later on. So the next set of slides here is all from the joint chapter. And in terms of what you need to know for exam purposes is what's on these slides is essentially what you need to know. There is a lot more information in the textbook about the joints themselves, but this is the information that you need to know for the exam. So stick to the things that are here, and that will guide you as you study through the joint chapter itself. So much like everything else, we can classify joints in several different ways. And so we can classify them based upon their structure, so what holds them together. And so we have collagenous joints, we have cartilaginous joints, and then we have joints that have joint capsules as well. And so we have synovial types of joints. And so the different types of structures that are there that help to hold them together. Collagen fibers basically spanning between the two bones. We can have cartilage that spans between the two bones and helps to hold them together. Or we can have relatively movable joints where we have lots of ligaments that help to hold them and limit their motion that's there. We can also classify joints based upon how movable they are. And so we can have synarthrotic, amphiarthrotic, and diarthrotic joints going from least movable to very movable. And so, when somebody thinks of a joint moving on the body, most people are going to think of a diarthrotic joint. And so this is going to be the most movable type of a joint. This is our elbows and our fingers and things like that as far as the joints goes. The next couple slides are from your book. Just kind of reiterating the information that's there within the chapter itself as far as the different types of joints and combining them together. One of the things that is important in terms of the joints is that we've talked about the bones allow for a much more efficient movement within the body. And so the muscles themselves are going to move the joints, and the bones allow for that movement to occur much more efficiently, stronger, things like that. And so when we have a joint, as we look at the joint itself here, again, we're always going to start in anatomical position. And so the first movement is going to be flexion. And flexion is going to take us from essentially 180 degrees in terms of something like the knee and reduce the angle of the joint. And so as we bend it, we're decreasing that angle of the joint. So from 180 degrees to say 90 degrees. And so flexion is a reduction of that angle that we had from anatomical position. Extension is just the opposite. We're going into an increasing angle as far as the joint is concerned. If we go beyond anatomical position, and so for the hip here, our normal anatomical position is 180 degrees. If we then increase that even further, we now get into hyperextension. And so hyperextension is going beyond that normal anatomical position for extension itself. And so that can happen even in the elbow here. We can do hyperextension for some people, especially in females. The shoulder can go into hyperextension, the wrist, and so on. And so we have that ability to go beyond the normal anatomical position for extension. From there we have our some kind of unique movements that can occur. And so abduction and adduction. So abduction, abduction, is taking the body part away from the rest of the body in a sense. And so abduction is to like abduct. And so this is where we're going to take it away from the normal position and take it away from the midline. A deduction is where we're then going to bring that joint back towards the body, more towards anatomical position that we were in before. And so abduction and adduction can happen at the shoulder joint, it can happen at the hip joint, but it can also happen in joints like our fingers and even our toes. And so now the midline becomes the middle finger or the middle toe for the hand on those. And we can then spread the fingers into abduction and adduction, bring them back together. One special movement that we have is supination and pronation. And so this occurs within the forearm itself. And so the radius and the ulna, the way that they are set within the forearm, allows for the radius to basically rotate around the ulna. And so it's going to go from its normal anatomical position where the radius and the ulna are right next to each other. And the radius here is then going to rotate over the ulna during pronation. And so supination is essentially anatomical position. So supination is palms up. You can think of supination as being kind of like needing to hold a bowl of soup. You would have your hands in supination or your forearms in supination. If you were to turn your hands into pronation and pronate the forearms, then you're not going to be able to hold that bowl of soup. At the ankle, we can do inversion and eversion. And so inversion and eversion occurs here as well. And so inversion is where we turn the ankle inward. And so inversion is going to be essentially walking on the outside of the foot. Once again, that inversion is going to be able to go a little bit further than that of eversion. And so eversion is walking more on the first toe rather than the side of the foot there. Inversion and eversion are oftentimes used for talking about things like ankle sprains, and so the most common of which is going to be the inversion sprain compared to the eversion sprain. But when you talk about biomechanics, we tend to talk about the ankle here in terms of supination and pronation as well. And so inversion is the same as supination, and eversion is the same as pronation. And so we have the same type of movement between the two sides, similar to that of the forearm. And so we can talk about them in the same ways. And so somebody who has high arches are oftentimes termed to be an over or a high supinator. And then somebody who has fallen arches go into pronation too much. From here we have special activity within the jaw. And so we have protraction and retraction, basically making an underbite and an overbite with the jaw. And then the jaw can also do elevation and depression. So we can raise and lower that mandible along that as well. And so both chewing types of motions that can occur within the jaw itself. One special motion that we have is opposition. And so opposition allows us to take our thumb and approximate it to the tips of not just the second digit, but to all of the tips of the fingers. And so we can approximate the tip of the thumb to the tip of each of the digits of the hand. And so that's our opposition. In certain joints, we have the ability to do circumduction. So basically, joints that have the ability to do flexion, extension, and abduction and adduction are generally going to also be able to do circumduction as well. And so this is essentially going around the whole movement itself. And so basically taking our forearm, our whole arm, and going out in front of us, and then up above us, and then behind us, and then back into anatomical position, takes us through flexion, extension, adduction, and abduction of the shoulder there. And so joints like ball and socket joints, saddle joints, condyloid joints are the ones that have the ability to do this. So things like our wrist and our thumb, in addition to the hip there, also have the ability to do circumduction as well. Since joints are going to be moving quite a bit, we need some protections in and around the joints, and so we have things that can start to go wrong. And so one of those things that can go wrong is bursitis. And so bursa are basically little fluid-filled sacs that protect the joint in terms of its movements. And so these are usually protecting things like tendons and ligaments in and around the joint, even sometimes muscles, from rubbing too much on the bones and things like that. But if we do something like fall or maybe lay down on the ground too long, in and around our hip or something like that, and it's hard, but usually it's some sort of trauma oftentimes, we may end up with bursitis because we end up inflaming that little sac too much, or if we're doing some sort of activity that causes us to essentially compress that bursa over and over and over again, repetitive activities, things like that, perhaps that we're not used to. Painting a ceiling over the weekend, you're holding your shoulders up into abduction for a very long time, and you're going back and forth and back and forth, and that ends up with shoulder bursitis. A little bit different from tendonitis, in which tendonitis is now the tendon or the sheath that covers over the tendon has become again inflamed, and this is generally from overuse as well. Sometimes tendonitis and bursitis go together, and so we can be having the same kind of a problem at the same time in and around the joint itself. When perhaps that tendonitis or bursitis has been there for some time and that's caused the joint to work abnormally, we could end up with things like arthritis over time. Other arthritides are something that we can't really prevent at all. And so we may have different forms of arthritis. And so we see that there's many, many kinds of arthritides that are out there. A lot of times the symptoms kind of come the same: joint pain, stiffness, swelling sometimes, heat in terms of them being hot as far as the joints are concerned. It all just kind of depends upon the particular cause of the arthritide itself. They can be acute forms where we know that something, in a sense, has happened directly to that joint, so things like bacterial infections and things like that. Or they can be long-standing osteoarthritis, rheumatoid arthritis, things that have been going on for years and years and years. Osteoarthritis is the most prevalent of all the arthritides. This is oftentimes kind of referred to as wear and tear on the joints. It's not necessarily a normal thing, but oftentimes it is age related. And so the things that we do when we're young and indestructible and things like that, that kind of hurt the joints once in a while, those may lead to small little insults on the joints that in the cartilage that ends up causing some sort of damage to the joints that over time has caused issues there. You can kind of think of like a pothole in a road. It doesn't start out as being that big hole in the road. It starts out as being just a small little damage to the road itself. And then over time, that wear and tear that is occurring creates a larger and larger and larger damaged area to the joint itself. So osteoarthritis Starts out as that little abrasion or compression to the cartilage of the joint itself, and it just keeps on breaking down and breaking down over time. Eventually, if it leads to complete destruction of that cartilage, the bones themselves will start to go through a reaction. So the ends of the bones where the articulation is will start to thicken and enlarge. This is a protective process that's going to go on within those joints, and so we might start to see osteophytes and extra bone kind of around that joint itself. Most common are basically the joints that move the most, and so things like in terms of the spine, the cervical spine, the lumbar spine. We see it in the hips and the knees, fingers, all of those joints that are the most mobile and the ones that are under the most amount of stress. Treatment early on for osteoarthritis is basically just pain control, and so mild pain relievers, things like that. Supplements like glucosamine and chondroitin sulfate can be helpful, especially for knee osteoarthritis. There's quite a bit of research that shows that it's helpful in there. Um, Everything up to and including then eventual joint replacement as well. Rheumatoid arthritis is another type of arthritis, and in this one, this is one of the ones that, in a sense, we can't really prevent per se, in the sense that if you're going to get it, there's nothing that you can really do about it as far as the process is concerned, because this one's autoimmune. We can't turn on or turn off our immune system, so to speak. And so when this occurs within the body itself, it's our own immune system attacking our cells that are there. It can occur really at any age. We can have juvenile onset rheumatoid arthritis. We can have older onset, and so kind of through the reproductive years or even after the reproductive years themselves. And a lot of the initial symptoms are the same in terms of there being joint pain and tenderness and things like that. But with rheumatoid arthritis versus osteoarthritis is you're going to have that pain be bilateral. It's generally going to be on both sides at the same time, whereas osteoarthritis, it occurs in just a single-sided joint most of the time at one time. One joint goes bad and then perhaps the other joint goes bad later on, but it's usually one-sided. Rheumatoid arthritis is also an inflammatory arthritis, so it's going to cause inflammation in the joints themselves, and so we're going to see that inflammatory process there in addition to the pain and tenderness and swelling of the joints themselves. Because this is an inflammatory process, we're going to see inflammatory chemicals inside the joints themselves. This brings about the immune response coming into the tissues themselves. This starts to essentially destroy the cartilage that's there, starts to destroy the bone, and we get what we see as what we call pannus formation. And so essentially this is kind of like a little notch in the bone, so to speak, and so part of it is actually destroyed there. This then leads to changes in muscle contraction, so we end up seeing some atrophy in certain muscles, and most definitively in terms of kind of the disease when it happens in the fingers is we see what we call an ulnar deviation of the fingers themselves. They start to bend towards the ulna itself. That's there, and so see that on things like an X-ray where we have the bones themselves. We have pannus formation within there, and then unequal integrity of the flexors and extensors of the wrist and hand leads to that deviation that occurs there. And the same thing can happen down in the toes as well. Treatment early on, once again, treatment has kind of progressed over the years. There's more and more biological types of medications that are available, more that are now going along the lines of being immunosuppressant in terms of the drugs themselves. But earlier on, it's basically kind of conservative therapy, deal with the pain and things like that, try and keep the disease from popping back up because it does tend to come and go. Another type of arthritis we have is gouty arthritis. And so gouty arthritis is, again, another one that to a certain extent you can't prevent, so to speak, but you can prevent by simply watching what the person is eating as far as their diet goes. And so gouty arthritis is the result of uric acid crystals building up inside the joints. And so these uric acid crystals, as they develop, uric acid is a normal byproduct of our normal metabolism. And so we produce some uric acid, but we also get it from things like meats and cured meats, especially kind of like deli meats. Mushrooms have a large quantity to them. Organ meats, in terms of foods and things, will have a large amount of the production of uric acid in them, and that's going to lead to exacerbation of the disease itself. Even things like wine and beer uh, increase the amount of gout that a person may have as well. The good thing is that diet modification can be very helpful, as well as medications to deal with the ability to get rid of that uric acid. And so basically, the body doesn't have the ability to get rid of it fast enough through the kidneys, and so it builds up within the body. One of the classic kind of areas where this occurs is in the first metatarsal phalangeal joint. And so in the big toe there, they get this buildup of the uric acid crystals inside that joint, and it causes massive inflammation to the point where this toe here may be so hot and inflamed and sore that they're going to seek out ER care. They're not going to be able to wear a shoe or a sock or even put a blanket on it when they sleep. Anything like that is just way too painful. And ultimately, it destroys the joint. If we put excess types of force through the joints, we can cause problems there as well. So just like we have fractures in bones, we can start to have problems in the joints as well. And so we can sprain a joint. And so a sprain occurs in the joint, a strain occurs to the muscles themselves. And so a sprain occurs when we essentially take the joint beyond its normal anatomical abilities. And so we start to either partially tear or completely tear the ligaments that are normally holding that joint together. And depending upon how damaged they are, it can be everything from immobilization up to complete surgical repair of the joint itself as far as the ligaments are concerned. A sprain may also lead to a dislocation. And so oftentimes a sprain is going to, or a dislocation is going to be accompanied by a sprain. And so this is where the joint is partially taken out of its normal anatomical position. And so we can have that joint completely out to where it's completely dislocated. It's no longer in its normal position. It's generally going to, in that case, sprain some of the ligaments that are there. Going to be very painful, going to have lots of inflammation in the area, but the good thing about it, in a sense, is once it's repositioned and brought back into normal location, a lot of that pain starts to go away and starts to fall back down. This can occur with a partial dislocation as well, where we get a subluxation of the joint. And so this is where it's partially out of place in a sense, and that can then be slightly put back together. And so generally less damage to the tissues at that point. And with that, we conclude our bones.